Good afternoon, dear friends. What we are discussing is an asymptomatic patient with left ventricular hypertrophy. So we'll look at this case, a 32-year-old male, asymptomatic, no dyspnea, no palpitation. Now he doesn't have any family history of sudden cardiac death and he doesn't have any unexplained syncope. Now remember before we start the echo to have these two history points very importantly to be evaluated because they form the first and second most important risk factors for a sudden cardiac death evaluation in patients of hypertrophic cardiomyopathy. Now, this is this patient's ECG, and you can see that there are deep T inversions and also ST depression. This is quite an extensive STD wave changes. Can this be an athlete's ECG? Very unlikely with this kind of an ST depression and deep Acon head T inversions. However, an athlete's ECG can be sometimes intriguing. Now, this is our patient's ECG and this is an athlete's ECG showing a J point elevation and ST elevation and a T inversion. Rather, this particular pattern of J point elevation and T inversion in V1 to V4 is benign and it is seen in many Afro-Caribbean athletes. So we'll look at the echo. Now our patient's echo definitely shows a left ventricular hypertrophy. Now can this be an athlete heart? Now, there are certain features of a echo which favor an athlete's heart. Now, the athlete's heart has got a much larger LV cavity and also larger LA size, while the HCM patients have a smaller LV cavity size and a large left atrium. So also the athletes have got a very symmetrical hypertrophy and there is never a dynamic LVOT obstruction. Also, the athletes have got a very well preserved longitudinal function like by E prime, S primes, and also E by E prime is less than 7, and the GLS is near normal. And also, the left ventricular hypertrophy can regress over the next 8 to 12 weeks of detraining. Now, when we are looking at the PLAX, let us look at the thickness of the septum. Why this is very important? Because this forms the third most important risk factor for sudden cardiac death when the maximum wall thickness is more than 30 millimeters. But however, you have to become cautious the moment you cross 28 millimeters. Now, why to look at the AML length? Now, remember many hypertrophic cardiomyopathy genotypes who have not yet manifested the phenotypical expression can still have a very elongated AML, and that can give you a clue that this patient may in future develop hypertrophic cardiomyopathy. Generally, the AML lengths will be much more than say 2.8 centimeters or 3 centimeters, so and so forth. Let us look at our humble M mode for a systolic under motion of the mitral leaflet, and this patient doesn't have any dynamic LVOT obstruction there. Let us look at the patient's four-chamber carefully. Here you appreciate the asymmetry of hypertrophy and so also the elongation of anterior mitral leaflet, and also have a look whether there is any systolic anterior motion. Now this has got a very mild systolic anterior motion there. Also scan the patient right from the base to the apex very carefully because this patient too has got a very significant hypertrophy at multiple places. Some patients may have just a small focal hypertrophy, and even that focal hypertrophy, if it is reaching 30 millimeters, it can still be arrhythmogenic. So that is why scan the patient from the mitral wall up to the apex for any focal hypertrophy, because that is one of the very important risk factor for sudden cardiac death. Then look at all the four chambers in the three axial planes, four chamber, two chamber, and long axis, and carefully look for apical aneurysm. Now remember, apical aneurysm forms one of the very important risk factors for arrhythmia. So also calculate the ejection fraction properly with Simpson's method. Now EF dropping to 50% actually puts the patient at a very high risk for sudden cardiac death. If you don't see the aneurysm, so our fourth and fifth risk factor for sudden cardiac death is the EF 50 or less, or any small apical aneurysm. Even a small apical aneurysm is also quite risky. So if you don't see the apical aneurysm well on non-enhanced echo, then use LV contrast of falsification and look for the apical aneurysm very carefully. Now these apical aneurysms can also develop over the next follow-up. So when you are following up these patients over many years, Each time, diligently look for formation of any apical aneurysm. Then let us have the patient's left atrium looked at very carefully by its focused views and take the left atrial volume. Now, any volume more than 34 ml per meter square, though it doesn't form a risk factor for sudden cardiac death, but it points to two things. One, that the patient's left ventricular diastolic function is deteriorating, he's developing more myocardial fibrosis, he may progress to heart failure, and not only that, patient may develop paroxysmal atrial fibrillation. Now, paroxysmal atrial fibrillation is not well appreciated in patients with hypertrophic cardiomyopathy, and it is one of the very major risk factor for developing cardioembolic stroke in these patients. Then let us have the strain map for our patient. Now, why this strain map is required? Obviously, wherever there is a hypertrophy, you will have a very variegated low strain values because this hypertrophy is not physiological. It is because of interstitial fibrosis. This strain map also give you a clue whether you are dealing with, like in this patient, whether you are dealing with some infiltrative cardiomyopathy, as you have seen here by the apical sparing. Knowing a dyssynchrony is important because that also tells you to the extent of myocardial fibrosis. Then always assess the LVOT gradient with certain maneuvers like Valsava maneuver or with exercise. Like in this patient, now this is a different patient. Now the rest gradient is less than 2 meters. The moment you do a Valsava, the gradient reaches almost 5 meters. Now this patient always had a normal resting gradient, but the patient used to feel very uncomfortable after lunch, and obviously that must be related to increase in the LV gradient postprandially. So we'll go ahead with our patient, and our patient shows a diastolic dysfunction. Now, why this is important? Because it gives you an insight that the patient is developing left ventricular fibrosis, and the LV is becoming more and more non-compliant, and the patient's symptom may become symptomatic over the next few years. Also diligently look for a TR jet and look for the PA pressures. Now the PA pressures can rise despite a normal LV systolic function in presence of a significant dynamic LVOT obstruction, and after relieving that obstruction the pH falls. So also the pH can increase if the hypertrophic cardiomyopathy progresses towards a restrictive cardiomyopathy or a dilated cardiomyopathy. Next step is to look at the patient's Holter. Now remember three words. If you get a non-sustained BT which is faster, which is longer, and which is more frequent, you give a significant weightage because this forms our sixth risk factor for sudden cardiac death in hypertrophic cardiomyopathy. So this patient has got this kind of pattern detected on the Holter. So, what is the hierarchy of all these risk factors that we looked at from the point of view of sudden cardiac death? So, the most important one is the patient's resuscitated cardiac arrest. The next in the hierarchy is the family history of sudden cardiac death in the first degree relative, especially at age less than 50 years. Any focal maximal wall thickness of 30 millimeters, but as I said, you become cautious from 28 millimeters, ejection fraction 50% or less, apical aneurysm, unexplained syncope in the patient. The third in the hierarchy is the non-sustainability, which is frequent, faster, and longer on Holter, and the lead gadolinium, which we will discuss later. The dynamic LVOT gradient, the LA size, the dyssynchrony, they do not feature in the ACC guidelines as their risk factors. What about the phenocopies? That means these patients have a significant hypertrophy, but they just mimic the hypertrophic cardiomyopathy, but they have certain other genetic disorder. So, what are the different phenocopies? Are the amyloid, the Fabry's, the PRKG2 mutations, the Tannons, the Nunans, the Pompe's, Friedreich's ataxia, mitochondrial myopathies, myotonic dystrophy, or rare like Niemann-Pick disease. There are certain red flags that you know that you are not dealing with a hypertrophic cardiomyopathy, but you are dealing with a phenocopy. So, what are the red flags? If the patient has a WPW syndrome, short PR interval, sinus node dysfunction, infrahysian blocks, patient needing pacemaker, skeletal muscular dystrophy, myotonia, elevated CPKs, patient having mental retardation, peripheral or autonomic neuropathies, or if the lineage is X-linked or maternal, unexplained strokes, tendon ruptures or cutaneous lesions, renal dysfunction. When these things are there associated with a significant hypertrophy, just think that you may be dealing with a phenocopy. There are certain red flags for amyloid, like unexplained heart failure with preserved ejection fraction, history of bilateral carpal tunnel syndrome, or if there is a dissociation like hypertrophy on the echo but the QRS voltages are not showing LVH, then the walls are thickened or the interatrial septum is thickened or the RV free wall is thickened, the reduced GLS with apical sparing, or unexplained atrial fibrillation. Now these are the red flags for an amyloid infiltration. And why do you need a CMR? Now remember, you don't need CMR for every patient. Now you need CMR when the echo window is poor and you cannot delineate the thickness of the myocardium. When there is a suspicion of infiltrative or storage disease, or when you want to be confident about diagnosing athlete's heart, or when the ICD decision is not very certain because you don't have all those classical risk factors, or you really want a very precise LV wall thickness in the follow-up, also very precise ejection fraction, or you are missing an LV apical aneurysm. Then the MRI has got the capability to look at the fibrosis, which is called as late gadolinium enhancement. Then if you are sending a patient of obstructive cardiomyopathy for planning a surgical resection of the septum, then MRI comes in handy to know how much septum to be resected for relieving the dynamic obstruction. You can repeat an MRI and follow up every 3 to 5 years. So this is our patient's MRI. And as you can see that this patient has got a significant hypertrophy, but there is no apical aneurysm here. You can get a precise left atrial size and volumes here. You can also look at the short axis images of the patient, and you can get a good stack of LV short axes at every 6 to 8 millimeters, and you can look for any focal hypertrophy, and you can measure it wherever you want it in the radial direction. So that's the power of MRI to give you a very crisp pictures to pick up this non-contiguous hypertrophy in hypertrophic cardiomyopathy. Then you can get a very precise ejection fraction. If you properly delineate the endocardium and the epicardium, you will get an ejection fraction and also the LV mass. Then you can look at what gadolinium is retained 10 minutes after giving the gadolinium bolus. And wherever the gadolinium sits in the myocardium, those are the areas which are having a lot of fibrosis, replacement fibrosis. So you can see that our patient has got a lot of fibrosis here. In the short axis views, you can see the areas where you can see the gadolinium is retained, and these are the areas which you call as late gadolinium enhancement, and they tell you about the amount of fibrosis, replacement fibrosis in our patient. We can use a certain software algorithms to actually quantify the volume of this fibrosis, and our patient has got 24%. Now, a late gadolinium enhancement above 15% is another important risk factor for developing sudden cardiac death. So also the MRI gives you certain parametric maps. Now these maps are called as netting T1 value maps, where on the short axis for every pixel, the MRI gives you a T1 relaxation time. So when the T1 relaxation time is very high, it will be seen as red. And you can see these areas of red. These are the ones where there is a lot of fibrosis in the myocardium. You can give the gadolinium and again repeat the maps, and as you can see here that wherever the gadolinium will be staying, the T1 values will drastically reduce. So you are seeing these blue areas and green areas where the values of T1 are low and the normal myocardium is looking yellow. So you know that there's a lot of gadolinium retained there. You can subtract those images and get the extracellular volume, and a higher extracellular volume is shown as this green areas here in the myocardium, telling you that there is a lot of fibrosis, and the the muscles are replaced by a lot of fibrous tissue there. So this is how the MRI can give you an insight into the myocardial characteristics for further risk stratification. When in doubt, and when you are suspecting ATTR after you have ruled out the free light, we have seen the free light chain assays and the serum protein immunofixation electrophoresis, both are negative. You can go for technetium pyrophosphate scan, and if the myocardium shows a significant uptake which is higher than the spine, it is a very characteristic for ATTR amyloid. Thank you.